case slides. All right, happy to invite our next speaker up, Mate Goya Arce, something like that. I did my best. Who's joining us from Mexico, so to join the International Congress of Neurology. So look forward to your case.
So good morning, and I really want to thank the chairs and Dr. Guzman for allowing me to present this clinical case, which I'll hope you find interesting, and I'm really looking forward to the discussion. I am a neurobiologist, so be kind with me with the MD questions, and I'd rather hear the discussion from you. Okay. So there's a 31-year-old woman that presents with widespread autonomic dysfunction. She's right-handed. She has graduate studies, and she's from Mexico. And I said this because the tests were not doing in tertiary centers or something. So one day when she's 8 at lunch, she begins feeling water in her stomach. And then they go make the lines to go to the classroom, and she gets paler and paler. She starts feeling like she's falling to the abyss and starts drifting away. She proceeds to lose consciousness for about 3 minutes, completely limp, and struggles to reincorporate. She's left extremely fatigued after the event. So what would be your initial impression? A vasovagal syncope, hypoglycemia, or an epileptic seizure?
So it looks like most people are saying vasovagal syncope. I'm curious about hypoglycemia. Why did people answer hypoglycemia? You're standing in line for lunch. That's because kids are perpetually eating. I've got 3 teenagers at home. So yes, Dr. Schondorf, I can agree with that. Kids are perpetually eating. Sure.
Okay. So this keeps repeating. At an age 10, she gets an EEG, and it's found that she has an epilepsy, a focal non-motor with impaired awareness. However, after the first couple years of treatment, she stopped losing consciousness, but she still had the episodes with the previous feelings. So an MRI and CAT scan were done, no significant feelings, and they were finally able to wean off the valproate treatment when she was 18, and she was discharged for neurological follow-up. So at 25, she starts feeling fatigue, nauseous. She presents hypotension, orthostatism, presyncope, and she also feels the fading away, the falling into the abyss. And she reports feeling like what she described internal physical decontrol and vibration. So she goes to a neurologist because her epileptologist had sadly passed away. He performs a TIL test where she presents hypotension, and then at minute 3, she has a 3.8-second cardiac pause, resulting in cardiac syncope with myoclonic jerking. So the diagnosis they give her is neurocardiogenic syncope. So she has symptoms still, and adding then gastrointestinal symptoms, she has to stop pursuing her PhD. However, making some pharmacological and non-pharmacological things, what I call behind the scenes, she was still able to work. At 28, she goes in for an appendectomy, and when they opened her up, she had internal hemorrhage due to a corpus luteum cyst. So after this, there's a severe increase in the autonomic symptoms. And she also begins having recurrent UTIs. She was actually like one really long infection, about 500 days, with a truly antibiotic-resistant E. coli. She actually finished in the hospital with urosepsis and only 3 antibiotics left before the bye-bye. So she has severe urinary dysfunction. It could take her even 40 minutes to start peeing. She always feels like she has to go. She has this sense of incomplete voiding, and she strains to void. So there were two urodynamics made during the UTI period, and they found that there was an underactive bladder with a detrusor sphincter dyssynergia. So after the UTI's resolution, they do radiodynamics. So we can see there's intermittent uroflowmetry pattern, but there is also a remarkably high urethral closure pressure. It's 120 milliliters of water, which is noteworthy because even if you see the upper graphic limit is 80 centimeters of water. So we find that there's a weak and poorly sustained detrusor contraction, and she's unable to generate bladder emptying. So what could be the reason for this continuous deterioration of urinary function? Is it still a consequence of the sustained and multiple UTIs? Maybe a nerve was injured during surgery. There may be an autoimmune component, or there may be some kind of neuropathy.
Are B and C the same answer?
Um,
Do we want to make, sorry, B and D. Do you want to make D a polyneuropathy versus B maybe D, and we'll make D an autonomic neuropathy,
Yeah,
and
exactly.
B is an iatrogenic mononeuropathy.
That's what I meant. Exactly. So by 20, I won't say the answer. So by 29 to 30, she has severe deterioration. She has debilitating fatigue. She has orthostatism, although symptoms can happen in clinostatism. She has hypothermia, bradycardia, which is especially during activity, hypotension, urinary dysfunction, and gastric dysmotility.
Okay, so we got to go back a slide, because yesterday evening we talked about words and terms,
How
and
do I go back?
You're there.
Okay.
Clinostatism. Tell us about that.
Okay, so let's just leave it that it doesn't need to be postural for the symptoms to happen.
Okay, so I actually don't know the word clinostatic. Any Greek speakers in the? I'm assuming
Yeah.
Yeah. So clinostatic means lying flat.
Yeah.
So clinostatic symptoms are symptoms that occur when lying down.
They could also happen
Like,
instead of
as in reclining, right? Like
no,
reclining?
so clinostatic is the opposite of standing up, and then she could have them in sedation, which is sitting down as well.
Okay. So the patient was having symptoms
in any position.
In any position.
But she had severe
Her symptoms were not.
orthostatism.
Her symptoms were not position dependent, but did get often worse standing. Okay.
Yeah. And there are some things that I highlighted that I cannot mention due to time, but maybe just look at them. So she has a severe deterioration, and I would ask that what would be, no, I'm sorry, I'm going the other way. But she still experiences this falling down, internal trembling, the physical internal decontrol, and it can last prolonged periods. It can happen almost daily and sometimes more than once a day. She has bouts and flares where symptoms are intensified, and she has perennial nausea. So by now she can't work. And then she comes to us.
One question about that. I mean, I think one thing we always, when people are having frequent spells, is really to dig into, obviously there's a prodrome she has, but then, how to quickly or not quickly does she recover after each of these?
So this is back. So we can say that they were prolonged periods. So they were not short. Later on, I'm gonna say the time, but they could last over an hour to several hours.
And I think the previous slide you had indicated she's sort of chronically hypotensive now.
Yeah.
So it sounds like she's evolved from having more discrete spells as a younger person, which might have been consistent with vasovagal syncope, but something that's not.
Almost daily, she could have about 70-30 or something like that. She could get 34 normally hypothermia, but she did go as long as 32.8. And her highest recorded heart rate during activity was 26 beats per minute. So she was not unconscious then, like she was still awake. So then, she comes to us, and really there's nothing to report about the physical examination, included the neurological exam. The cardiac evaluation is relatively normal in the sense that the Holter was made inpatient and not in activity. And we have seen that the bradycardia was mainly during activity. But however, in the treadmill stress echocardiogram, everything's fine. She achieves maximum effort, but then she has a vasodepressor response. So she gets a systolic blood pressure decrease of 20 milligrams of mercury, and this persists throughout the recovery period. And she gets severe pallor and dizziness, and the test has to be stopped. So I would ask you, what would this response can be to? So maybe there were blood pooling in the extremities, or volitional exercise can induce hypotension without altering the heart rate. There was dilation of blood vessels, or maybe it was secondary to medication. She was on atenolol then and midodrine.
So I think you're saying that during exercise, her blood pressure dropped by more than 20 millimeters systolic.
Yeah, so they did at stage 4 of the test. Her heart rate was fine, and suddenly she got like hypotension.
So in addition to dropping, she was actually hypotensive.
Yeah, she was doing fine. She was at 78 maximum effort. Everything was doing fine. She achieves maximum effort, and then she has the vasodepressor, but it was only the pressure that went down.
Heart was still doing fine.
Heart was still doing fine, yes.
Okay, we're over 40 answers. The predominant one, about half of the people are taking the answer C, dilation of blood vessels, presumably peripheral arteries. And then smaller numbers for the other choices. So I think we can go forward.
So studies conducted for the differential, we had whole exome sequencing, paraneoplastic syndromes were ruled out. We also had an autoimmune autonomic panel, which is the Mayo panel. We couldn't get the Celtran. And we did do a brain, spine, and pelvis through Tesla MRI, which showed no significant structural damage. And however, the video urodynamics, the condition had worsened. She had weak and non-sustained detractor contraction, which failed to produce urinary flow. We did a gastric emptying scintigraphy, and she showed gastroparesis. And then we decided to also do a video EEG, since she had epilepsy as a child. So it was a not very nice EEG. She actually presented a 40-second generalized seizure with no component observed in the video EEG, but she reported feeling the falling, the internal decontrol, and the vibration, and she was fatigued afterwards. So we started an anti-seizure medication regime. She didn't, like they are infamous for the side effects, so we tried two that she couldn't handle. We tried lamotrigine treatment, which completely alleviated the cardiovascular symptoms and the hypothermia. However, she still had nausea. She still had GI dysmotility, and the urinary dysfunction was controlled by a sacral neuromodulation placement. So how would you explain why cardiovascular symptoms and hypothermia improved, but some symptoms remained? Maybe lamotrigine has cardiovascular effects. Epileptic seizures may be playing a part in the dysfunction observed, or we could be in front of two different disorders.
So the video EEG, if I can summarize, showed a generalized seizure pattern
Yes.
without loss of consciousness.
No loss of consciousness, no motor component, but she did the free falling and the internal decontrol feeling she had. So actually, I mean, I don't want to be like, I cannot take too much time, but she had the bitemporal spike waves, and then she had secondary generalization.
And those episodes correlated with these internal feelings she was getting.
Yeah.
Okay. And hypotension during the.
No, she didn't
No.
have hypotension.
Okay.
But lamotrigine alleviated completely the cardiovascular and the hypothermia.
So 2/3 of respondents are saying this is probably there's probably two different things, epilepsy and something else. And another third thought that the epileptic seizures may be contributing to the autonomic dysfunction. Both are true.
Okay. So despite the ASM regime, the EEG still came out quite well, somehow abnormal. She had lateralization to the left side. They were focal, but the foci would be temporal, central, or frontal, like they would change around. She had hyperventilation, hypersynchrony, which is normal in children, but not in adults. And she would have a slowing of background and some transient disorganization. She also reported experiencing prolonged periods of fatigue, general malaise, nausea, pallor, some paresthesia. They could be perioral, cranial, or in the right arm, and some pilorections, especially in the right limbs. She also reported the prolonged feelings of free falling, the vibration feeling, especially in the trunk and arms. And what I found astounding is that after the placement of the interstim, she could now describe the internal decontrol feeling as feeling voltage. I don't know if you know how it plays them, but you really get voltage into the nerves. So these episodes were followed by extreme fatigue. The episodes could last from over an hour to a couple of days. Sometimes they were clustered. The periods of time, they were periods of time in which the frequency and intensity would increase. Symptoms would wax and wane, but nausea, fatigue, and GI dysmotility remained relatively constant. But they intensified during and by the episodes and during the periods of time in which the frequency and intensity would increase. And they were usually triggered by any type of exertion and by sleep deprivation.
So I'm curious if I were to kind of summarize this case right now, if Steve and Maite, if you want to give me your thoughts on this summary, we have a woman in her 30s with a long-standing history of spells that sound like vasovagal syncope, who's been diagnosed with bitemporal epilepsy with secondary generalization, who's also developed neurogenic bladder versus detrusor failure and gastroparesis.
She had, like all GI dysmotility. What we could show was gastroparesis, but apparently it could take like transit time could be up to 8 days.
Okay, so it's long-standing history of spells that sound like vasovagal syncope, a diagnosis of epilepsy with subsequent urinary emptying and gastric motility failure with ongoing non-orthostatic spells. Is that kind of where we're at?
Orthostatic spells were constant, but symptoms were not only orthostatic, but she did have orthostatic response, like getting dizzy if she stands and stuff. So now that, no, they were not.
Were any blood samples taken during episodes was the question. No.
Yeah. So now that we have epilepsy in the mix, let's go back a little bit. So we can remember that at age 10, she had epilepsy. It was a focal non-motor with impaired awareness. However, after a couple years of treatment, impaired awareness went away. However, she took like 8 years to be weaned off valproate. And we know that seizures and epilepsy are not the same. A seizure is abnormal or excessive synchronous neuronal activity, but that doesn't mean you have epilepsy. Actually, for epilepsy, you need to have unprovoked seizures. And as you know, if you have a syncope, you could have like seizure activity reflects in an EEG, but that is a provoked seizure due to hypoperfusion in the brain. Reflex seizures are not reflex syncope. They are really interesting. Some cases I can tell you is you put a baby in the water and it will start seizuring. Or there was a case that a woman that had like a unique thought and that would cause her seizures. So reflex epilepsy is completely different. So if we remember, she has the water in her stomach, the falling down on the pallor, and this is called an aura. And an aura is a seizure in and of itself. In the 2017 International League Against Epilepsy, which I will call the ILAE because I'm Mexican, it's called the focal onset aware non-motor seizure, and they can have autonomic and sensory symptoms. So the watering in her stomach and the free-falling feeling, they're called epigastric auras, and they are considered autonomic auras. And in epilepsy, as in everything, the devil is in the details. Such subjectivity is really important because it tells us exactly or where could the seizure start and or the first region that gives symptoms after propagation. So as we said yesterday about Dr. Goldstein, it's really important taking the medical history, and subjectivity what we call subjectivity can be truly important because not all areas of the brain are motor. But here she seems to be having the really prolonged somatosensory and autonomic auras, and she's retaining consciousness, not only awareness, but she's conscious. And she has a non-motor component. So is it possible for an aura to last that long? We know that prolonged seizures, and we just said that an aura is a prolonged seizure, is a status epilepticus. And we know that that's not good, right? Like if you see someone with a motor seizure in 5 minutes, you have to run to the hospital. So it is possible, but it's really rare, probably underdiagnosed for the subjective part. So it is actually in the ILAE's classification of status epilepticus called a focal non-convulsive status epilepticus without impairment of consciousness. Throughout time, it has been called aura continua. It's easier to say, so I will use that term. It's important to know that status epilepticus has a different classification because due to the time and the duration, we're not dealing with seizures. So in aura continua in general, the patient is able to relate the symptoms. They can be mainly subjective, they can be autonomic, they can be somatosensory, and they are always reflective of the cortical area of dysfunction. So it's the only kind of status epilepticus that can last from hours to years. It may wax and wane, and the episodes can be recurrent and clustered. And it's considered extremely rare. There are only case reports and one EPC series that Dr. Wolf and Dr. Ruta Maminiansky made, and they think that epilepsia partialis continua is the motor counterpart, so they include 5 sensory cases. So the thing about aura continua is that scalp EEG may be normal during status. But if we have activity, it shows focal or lateralized epileptic discharges and or slowing. So you need high clinical suspicion to be necessary to consider the diagnosis, and you can do a benzodiazepine trial to confirm it. Benzos are the first line of treatment against status epilepticus. So upon semiology, which part of the brain or epilepsy could evolve and cause both somatosensory and autonomic aura continua? maybe it's a temporal lobe epilepsy, an insular epilepsy, or a mesial temporal lobe epilepsy.
While they're answering, I think you said way back early on in the course of things, there was brain imaging that was unremarkable. Was that repeated with high strength magnets to look for small cortical dysplasia?
So when she was 10, she had an MRI and a CAT scan. Of course, MRIs back then, at least in Mexico, were just 1.5 Tesla. And in epilepsy, they're considered to, you need minimal 3 Tesla to prove lesions. And also with aura continua, normally you have lesions like focal cortical dysplasia or cavernomas, but it was repeated and there was no significant findings.
Okay, and the poll is about 50% insular cortex epilepsy and then split between the 2 temporal lobe etiologies. So we can wrap up. Go ahead.
Oh, I'm sorry, then I'm gonna run. So a bit about insular epilepsy. It's called the great mimicker. Even Penfield and Falk in their amazing 1955 paper, it's surprising that the results of their stimulation are confusingly varied because it's surrounded by a remarkable variety of functional areas. It also may not show in scalp EEG, but if it does, it's normally frontal, temporal, or central and will allow lateralization. Insular stimulation can completely inhibit gastric movement. There is insular anterior cingulate involvement in micturition. The left insula is normally involved in parasympathetic functions, and the presence of early visosensory and visoremotors are also subjective to ictal discharge in the anterior insula. Also, insular epilepsies, patients tend to keep awareness and not lose consciousness. But when you have a mesial temporal, which propagates to the insula, people can lose consciousness. And one of the main things is a laryngeal spasm. And this is the thing about, I told you, subjectivity. So the patient had never reported anything. And they asked her if she had a feeling in her throat, and she said that she always felt like she was gonna get sick because she felt like she was swallowing phlegm. And the insula can cause hypotension without heart rate variation during volitional exercise. And their auras can include the electric feeling, the vibration, the nausea, the epigastric aura, and the pallor. So we make a benzo trial, and it was completely successful. And now, so we proceed to confirm if she does have an epileptic focus. So we do an interictal cerebral PET-CT. Interictal means it's not during a seizure. And because epileptic activity, especially prolonged one, causes neuronal dysfunction, if the seizure is not occurring, we would find hypometabolism, which would be green, right? So here we do the PET scan, and we can clearly see that the left anterior insula is completely hypometabolic, which is subjective to the epileptogenic zone. It had already expanded to both anterior cingulate gyrus and the ipsilateral superior frontal gyrus. So the diagnosis so far is focal left anterior insula epilepsy that can present itself as aura continua. And just the cherry on top of the cake, something we got last week, is we had wondered if the status epilepticus is affecting autonomic function like GA dysmotility, what would happen if we administered a benzo before the gastric emptying study? So she always had bad gastric emptying studies. So we administered clobazam 30 minutes before the study started. Its peak concentrations are between half an hour and 4 hours, which is what the study, the duration of the study, and we got a normal emptying study. So I'm here for your questions and really the discussion and the feedback.
Dr. Benaroche, I'm bringing in the microphone. I'm going to play Rover here. Dr. Gould, I think you're up next.
This is a very interesting case. Now, let's assume that we have two different scenarios. Forget about the EEG, forget about the seizures for a while. I will have a patient who's a young woman who has vasovagal syncope, poor gastric emptying, and blue bladder emptying, that many frequently we see patients with this problem with gastrointestinal dysmotility and micturition defect due to pelvic floor relaxation defect. And we have chronic nausea in this setting. That's a patient has any history of migraine, by the way?
She did have postictal cephalea
Correct.
the first year when she was
Correct.
a child.
So if we have the scenario in which we don't have the EEG and the beautiful insular possibility, we say, well, this is a prototypical patient that we see with vasovagal syncope, gastric dysmotility, and pelvic floor dysfunction, creating a Fowler syndrome with poor bladder empty. Correct?
Mm-hmm.
So that would be in a scenario. Perfect. Now we have a patient in which you have an initial seizure recorded that were treated for a while, and then we stop the treatment. Then you have a patient that comes back with the symptoms in which you have residual symptoms that we don't know if they are inter or interictal, because now we need to show me that the symptoms occur at the time of the seizure. Because, of course, seizure has to be stereotyped, and the typical insular seizure is not stereotyped. So that's very nice. But the important issue is to determine whether or not the symptoms are interictal or ictal. Because if the patient is still having symptoms with a seizure arising from the insular cortex, you need to do a intraoperative recording of the insula, because the patient will be at risk of sudden death if it's not treated appropriately. And lamotrigine, although it's a great anti-epileptic medication, is also an anti-migraine, antidepressant medication. So the fact that she improved with lamotrigine does not necessarily mean that it's an anti-epileptic effect. So I think it's very critical in this patient to make sure that really the symptoms are ictal, and second, to make sure these ictal symptoms are due to ictal discharge from the insula, because she's not treated appropriately if she's having seizure from the insula.
Can I throw a twist in there? What if she has interictal symptoms? Could you contrive a situation where there could be a channelopathy causing autonomic failure and epilepsy?
Epilepsies are stereotyped by definition. The least stereotyped is the insular epilepsy. A channelopathy can produce this, but can produce cardiac defect at the same time if there is a potassium or sodium channelopathy. Of course, can be. I don't know if a channelopathy that produces specifically insular involvement as opposed to a generalized, primary generalized seizure disorder, but maybe.
So if I may comment back, the thing about here is she had about a 68% probably of recurrent epilepsy, and there was no EEG done at the beginning. And she had like deterioration during time, right? And the thing we're talking about, it's not necessarily focal seizures, but an status epilepticus. And the problem about the insula, exactly, it may not show in the EEG. And the thing about lamotrigine, normally even Gowers studied before that sometimes you take away like these spectacular symptoms and some symptoms remain, right? So the fact that she completely responded to benzos and completely ameliorated, it's a good indicative that the problem is this status, right? She hasn't had the stereo EEG because they are not recommending surgery and it is truly invasive. So that's not being considered right now.
All right, we're going to give Dr. Gould a moment for a question or comment. Dr. Senior grabbed the microphone, and it's our break time too. So,
Yeah.
I have a quick question. Thank you for the presentation. The first thing is that this patient had an EEG in the past and had temporal spikes, I think, after the first episode. And semiology looks very similar to what she experienced in late 20s and early 30s. and then Depakote was weaned. So my question is that, were you guys able to capture an episode before weaning Depakote and decide that, oh, like the semiology doesn't fit what's going on, or like something else? What was the decision making behind stopping Depakote? And the second, I was going to ask about in-depth electrodes, and as other question stated that it's very difficult to capture insular seizures, right? Because of the location, and the scalp PG doesn't really find it. So how are we going to make sure that the patient seizure free in the long term?
Okay, so let me see. The last question is, we are trying a regime that would stop the focal seizures and not really just stop them once they happen with the benzodiazepines. Oxcarbazepine, it's being treated alongside the lamotrigine, didn't have that much well response. The next one we're going to try is cenobamate, which it's supposed to be really good with focal seizures. And the other thing you said, can you repeat the other question? So yeah, she stopped having symptoms, but every time they try to wean her off, she would feel fine, but her EEGs were horrible. So they had to get her back. Back then she started with valproic acid, and they were able to change it to valproate because of side effects. And yeah, the fact that she took that long to be weaned off is one of the recurring factors. Probably that it raises the probability of recurring epilepsy.
All right, very good. This is a great session. I had a lot of things to think about. Obviously, we're over time, so we'll let people head out for a break, and I guess a short break. We'll try to get close to back on time at 10:30 for the next sessions. They need time to split the room, I believe, at this point. So everyone needs to get out.
Oh, thank you.